Good morning, everyone. Thank you for being here with us. Happy Monday. My name is Katie Earle. I'm the coordinator of the University Express program, and we're joined here virtually with Dr. Lito Gutierrez. Very thankful for him to be giving us his time today. Before we get started, I'll let you know that we are recording this session and we'll try to repost it on the website at a later date. And also, as you heard, you're muted and there's no video of yourself showing and you haven't done anything wrong. That's just the settings that we have for this program. Want to make sure the new people joining us here today knew that. And you also might think you're the only one in here with us today, but I promise you there are a lot of other people. It's only that Lito and I are able to see the complete list of everyone who's in here. And please send us your questions and comments throughout Lito's talk. He'll be able to answer those, and I'll be helping to monitor the Q&A as well. So for some of you, that Q&A panel popped right up on the right side of your screen when you joined. You might just have to expand it, and then you'll see the text box. So send us your questions and comments. Click send. If you're not seeing that, if you're on a computer, and if you look at the bottom right-hand side of your screen, you should see a little button that has a box with a square and Q&A. Click on that, and if you're on a tablet, poke or touch your screen, you'll see a circle with 3 dots, and then you'll have your Q&A. So we hope you find it. We hope you ask your questions and give us your comments, and then we'll learn together today. I want to thank the sponsors of our University Express program, which is my Department of Senior Services of Erie County, Blue Cross Blue Shield of Western New York, Excelsior Orthopedics, and Wegmans, because they help make this program possible. And obviously, I'm going to let you know that Senior Services is here for you. If you have any questions about programs, services, or benefits for yourself or a loved one, don't hesitate to give us a call. We're at 858-8526. I'm going to introduce our speaker today. Lito Gutierrez graduated as a physician at the Mendoza University in Argentina in 1966. His internal medicine residency with the UB Medical Department affiliated hospitals was completed in 1971. He practiced primary care internal medicine in the New York State Southern Tier, so Jamestown and Salamanca, until 1989 when he joined Healthcare Plan in Buffalo. He was chief of medicine at HCP until 1998, when he then became the medical director of the regional medical unit at Wendy Correctional Facility. Lito worked as a physician at the ECMC Immunodeficiency Clinic until 2005. He served as a medical coordinator for the Western New York Office of Professional Medical Conduct until 2012. And Lito was appointed as a member of the Public Health and Health Planning Council of New York State in 2012 and still serves in that capacity. So I'm looking forward to hearing what you have to say, Lito. I'm going to toss it over to you.
Thank you. Thank you very much, Katie. Good morning, everyone. I cannot see a picture of everybody, so I see Katie and nobody else, but that's okay. I know you're there. This is going to be a lot of storytelling, I hope, relating to experiences I have had watching the transition from care given in the 60s and 70s and 80s onto what happened today, accelerated by the effect of what is going on now, which is affecting all of us, which is a COVID epidemic. Part of the first story is a recent one. My wife and I, in April of this year, volunteered to go to the Javits Center in New York City to help with the work there. We did not go in the first line of fighting. We were more a support staff, but it gave us an opportunity to witness what was going on in New York City, and also with the aftermath of the hospitalization part, because Javits Center had become a place where people that were approaching readiness for discharge or were discharged and didn't have a place to go ended up being sent to. An incredibly busy place, in spite of what you may have heard. Yes, not all the beds were utilized, but the main reason was not that the beds were not there or that the demand was not there. There was not enough staff to provide the care for a total of 1,000 patients. So the limit was set at 500 at its peak. And it was very busy. when you are working in a place where there are 125 admissions a day and at the same time 75 or 80 discharges, you are busy. And one of the first things that I learned in watching the activity there was something that the civilian medicine did not have and the armed forces did have, which is the ability to do proper triage. There was a particular individual, Lieutenant Colonel Guy Travitt, who, in my eyes, was a hero. He is an oncology surgeon. He works out of Fort Sam Houston in Texas, and he's a lieutenant colonel. He was able to walk in a chaotic emergency room and decide who was going to get immediate care where and who did not need to be in the emergency room. Something that for some reason the civilian physicians did not appear to be quite as efficient as the military. So learning from the military is something that is affecting the way we practice now and will continue to affect going forward. Another element of the military that is a lot to learn from is the use of what in the military are called the medics. In the civilian life, you could think of medics as the EMTs, but you also should think of the space between the EMTs and the physician, which is occupied by people that have a differing designation, nurse practitioners, physician assistants, and a number of other titles that have not been entirely used or have not reached the peak of their usefulness in the practice of healthcare today. Some of you may have heard me when I was talking on the subject of why hospitals close, and I will touch on that a little bit. I suspect that the population that I'm speaking to today are mostly people in my age group, 60, 70, 80 and above. And you may have witnessed what I witnessed. I came to Western New York in 53 years ago. And in the past 53 years, no less than 25 hospitals had closed, gone in the area of Western New York that goes from the western margin of the Genesee River all the way to Lake Erie. Where did those hospitals go and why? Well, many of you know the answer is a success of preventive care and public health. We no longer admit many illnesses that require hospitalizations. In the past, we have fast treatment for many of them. Many have been eliminated. Smallpox no longer exists. There have not been a smallpox case diagnosed in the world for about a decade. Polio remains largely controlled, and many other diseases that have vaccinations are now controlled. We have reduced the hospitalizations for OBGYN. The bread and butter of hospitals used to be admissions for birth and surgeries. But the old laparotomy, which meant opening the belly to see what is there, is now practically obsolete. You don't open somebody's belly unless you have full imaging of what is there. And you know precisely where you're going to go. So the large cut that you needed to make, if you remember Lyndon Johnson showing his gallbladder operation scar, that is seldom seen nowadays. You have tiny little keyholes from a couple of them. One goes for the optics and the other one goes for the instruments, and surgeries like a cholecystectomy and many other hysterectomy, multiple other ones are done through that procedure, and the hospitalization length has shortened so that hospitals are suffering because the bed utilization is down. So if you were able to freely walk the wards of the Buffalo General Hospital nowadays, you will go through places that look closed. It means entire floors are closed. And a hospital that is registered with X number of beds, generally into the 100s, you do not have those beds actually being utilized. So how are things changing also otherwise? Well, let me tell you, there is a large conglomerate of hospitals in New York City, nowadays known as the Northwell system. I was stunned when I heard this. The Northwell system now is the largest employer in the city of New York, in the 5 boroughs. And it's basically a number of big hospitals that have joint efforts in providing hospital care in the city. In fact, in the last meeting of the Public Health Council, of which I'm a member, as Katie mentioned at the beginning, we discussed the fate of a hospital in Brooklyn, which has been kept open mainly because it is needed to be there in case of a surge situation, like what they had in New York City at the peak of the pandemic in the city. You need to have beds that are readily available to take that wave of patients that come in a situation like this. But the economies of scale, the ability to buy 1 million personal protective devices versus buying 50,000, there is a cost that it represents a saving to the system, and that is passed on and allows the system to survive. The other big change that I see, and I predict will continue to get bigger, and given my age, you may assume correctly that I see this or say this with a bit of regret, because the personal contact with the physician is becoming more and more a part of history and not reality. The impact of telemedicine nowadays is significant. It will continue to grow, and it will become absolutely prevalent. The other thing that will happen is that, and in previous talks I have mentioned this, those of you who have as your primary care physician somebody my age, I'm 79 years old. I've been retired for now quite a few years. But you may want to find a younger physician, somebody who's going to be around and not going to retire just before you need them most. And how do you find a new physician? Look for a physician that works in a group that is well supported by a good, solid group of PAs and nurse practitioners, because your care will most likely be delivered by that level, and you will not get to the level of physician care until you have cleared a few things that will be taken care of through telemedicine. I would not be surprised, and this is one of the things that having to talk on this kind of system doesn't allow me to see. I would ask you for a show of hands of how many of you communicate with your physician through a computer. I would not be surprised to see that there's a large number of hands going up, because that's the way you do things nowadays. But again, at a recent meeting of the Public Health Council, I was impressed with what had happened with mental health care in the city, where transportation, particularly in a time of pandemic, was difficult. And there were some striking things, positive things. people that were notorious for their non-compliance, meaning not showing up for follow-up visits in the mental health system, were doing better during the pandemic because they did not need to leave their house. They communicated through things as simple as their iPhone or through their computer, and were doing better during the pandemic because they use that way of communication. That created a problem in an area like the Adirondacks and the Southern Tier, I'm sure. I worked in the Southern Tier for a couple of decades. I'm sure that that's a problem there. Many people do not have access to internet or proper communication ways. And the idea is coming into play now to consider in every little town throughout the state that has a library or a fire department or a police department to make room and communication wavelength available to people that are in isolated situations so they can talk to centers where their care could be managed and attended to. Telemedicine has been used for a long time, particularly in prison medicine. You heard when Katie was talking about my working for the prison system. I was in Wendy Correctional Facility and I managed a fairly sophisticated unit, the Wendy Regional Medical Unit. And consultants came to the unit and will do telemedicine, and I'm talking about 2005, telemedicine for patients that were in the prisons of the area like Attica, etc. So that's not new, it's quite advanced. What is new and actually remarkable is to what is happening as I speak. This is my iPhone, and many of you have an iPhone or something similar, and that's the bottom of the iPhone. In this little connection here, you put a cable that is connected to a blood pressure machine, an oximeter, a glucometer. Oops. Am I there?
No, I think you stopped your video.
By mistake.
Yep,
Hold
that's
on.
okay.
Let me get back on. I was moving the computer and things went blank. So I'm sorry. That's a problem with technology. You don't want that to happen when you're talking about to your doctor about chest pain. In any event, here we are. Through that place, you can put information that the person that is the healthcare deliverer at the other side of the line can see how you're doing very accurately. In fact, one of the other changes that we are seeing in New York City in particular, and now in many other big hospitals throughout the United States, during the current surge of the pandemic, a lot of people don't get admitted to the hospital because they are not sick enough to justify they are utilizing an intensive care unit bed when they could be taken care of at home. They are sent home with all the devices, so they are connected to the system and they're constantly monitored. So we are all familiar with measuring our own blood sugar. We are all familiar with taking our own blood pressure. Many of us are using oximeters now. Well, it goes beyond that. There are other things that are being detected without poking the skin and can be reported to a center or a hospital where you will be monitored from in a remote fashion. That is happening as we speak. The thing that is also happening, you heard me talk about the role of the medic or the role of the PA and the nurse practitioner. I have personally worked with nurse practitioners and PAs practically my entire medical career. And we had nurse practitioners in Salamanca back in 1975. And from then on, all the time, I work with nurse practitioners. Nowadays, nurse practitioners can practice on their own in collaboration, but not supervision necessarily, collaboration with a physician. PAs need to be supervised by a physician. Medics also are under the supervision of physicians or PAs. One of the topics we discussed at the Public Health Council and the Committee of Public Health, which is a separate subsidiary committee of it, is the future of that ancillary care, particularly in areas where the availability of physicians is not very high, or in situations of a surge, like what we have experienced in the spring and what it looks as we are experiencing now in many places. Where do you go to find the people that will take care of the ventilators and the sick people that are being admitted that overwhelm the current staff of a hospital? Interesting that I don't know how many in the audience are, for instance, firemen or policemen, or for that matter, EMTs. The amount of training that these people have already acquired through their courses and taking care of people that are sick is tremendous. The EMT that goes in an ambulance to pick you up when you call because you have chest pain knows not just how to hook you to a monitor and to start an IV, but he can read the monitor, he can transmit the monitor, and he do interpretation of the monitor, so he knows when he or she will need to act immediately because you're going into fibrillation. He doesn't need to wait for a physician to say, you need to resuscitate. So the medics in the armed forces are probably even higher, a higher level of training because they are alone in the battlefield. What they have is a method of communication that allows them to call the hospital and decide with the help of somebody at the hospital level on what to do. Communities that are not isolated communities could be making use of that at a higher level, with a higher frequency. And I believe, this is a personal belief, that the time has come where you could safely advise young people that if they have free time, they cannot find a job, and they want to occupy their time appropriately, go and get yourself trained as an EMT, or train as a fireman, or train as a policeman. Because when the surge comes, there will be what we be equivalent to a National Guard for health. The states can call upon to help with the time of the surge. And those are the ones that will be minding the respirators and the laboratory results and the fevers and the oximetry of people that do not need the attention of the intensive care unit specialist. There are multiple changes being made in technology, and they are so vast that I'm not going to go on that at this point. I've already been talking for 25 minutes, and Katie is there looking at who's asking questions, and she's going to tell me which questions will move. I will entertain all questions, but at this point, I like to concentrate on the ones talking about the changes on how medicine is being delivered and will be delivered. What is happening now is easier to ascertain than what will happen in the future, but I think I have a pretty good, from the vantage point I have, I can give you a pretty good idea what I see coming from the Public Health Council. Katie, what do you have there?
So far, so there's one question we can leave for the end because it's a little different. And then we have one person that is currently receiving telemedicine with their physician.
Okay. So can that person talk, Katie?
Not currently, no.
Okay.
They can type in though, if they want to.
Okay. So I would like to know, are we talking about a he, she?
She.
She. Would she be willing to tell us in a couple of words how is the level of satisfaction with the telemedicine?
I will let you know if anything comes through from her.
Okay. All right, let me move on. Oh, I see how physicians can assess a patient without seeing them. Well, I think that there is a lot of the data that goes into a physician's brain at the time of the interview that comes from listening, seeing, feeling, and smelling. And so, yes, there is a difference, and you cannot say that telemedicine will be able to supplant, to change, to alter much of what was used in the old or the traditional system. But let me tell you this: my ability to make a diagnosis. At the time, I was working in an office that is probably close to many of you. I was in the West Seneca branch of the healthcare plan system, and there were studies coming at the time measuring the time spent by the doctor listening to the patient from the opening, how are you? Or what brings you to see me today? And how long it took the physician to interrupt the patient as the patient was delivering his or her complaint. And what was impactful to me is to realize that we physicians were not listening. We were jumping on to asking questions before the patient was done telling us the reason why they had come to the office. The physicians interrupted on an average in about 20 seconds from the time the patient began to talk. Physicians, when asked, why are you interrupting so quickly? The answer was, because I have 15 minutes to see this patient and he's using all the time I have telling me the story. I said, okay, let's try and see what happens if you just let the patient talk. How long will it take for the patient to talk him or herself out? And it was interesting for me, certainly, to find out that the average time it took the average patient, okay, to talk himself out was 1 minute and 27 seconds. But for physicians that did not interrupt the patient and physicians that did interrupt the patient, the diagnostic accuracy went up and patient satisfaction went up when the patient was not interrupted. Let me also put out a number for you to go and check out. And you can please check with your own physicians. Better than 90% of the diagnosis is made by listening to the history. Because as a patient is talking, I am shifting up and down my differential diagnosis, which is the list of things that this patient may have, according to what I hear the patient say. And when I go to examine the patient, which is the briefest, or should be the briefest of the interactions in the average visit, I have some things in mind that I want to check. So I'm going to address my examination to the eyes if the problem is one of vision, to the neck if the problem is one of neck pain, or to the feet if the problem is with the feet. So what is the value of my listening to the heart or listening to the lung if the patient is not complaining about that? Particularly if I happen to have a monitor that is telling me what the patient is doing or an oximetry that is telling me how the lungs are doing. So we have a lot to learn about how technology can help us and help us make best use of the contact through a computer or telemedicine, which is more akin to this audio visual thing. You are seeing the patient on telemedicine. When you're just talking on the phone, you're not seeing the patient. I hope I've answered that question. Let's go with the next one. Katie.
Okay, we have people saying that their telemedicine appointments are excellent, primary care and mental health counselor. A question I'm seeing is it proper to ask a doctor their age in future plans?
Sure. I don't see why not. But you have another way of finding out their age. Find out when they graduated. I graduated in '66, for crying out loud. So unless I was 2 years old at the time, I have to be my 79 years old. I don't see why not. I would think that if a patient that is engaging on a contract with a physician, and it's a contract, I am here to be your patient, I'm engaging you to be my doctor. You don't sign much. You sign plenty of documents, but none of them is quite explicit in that sense. You are entitled to ask, where did you go to medical school? Where did you do your postgraduate training? And did you take your boards? Are you board certified? I mean, you want a certificate of it will be an equivalent to the good housekeeping seal of approval. Are you board certified in your specialty, surgery, internal medicine, pediatrics, etc.? You are entitled to ask those questions. Next.
Okay, that one person had responded, I've had telemed from my endocrinologist in Roswell. I couldn't get my camera to clearly show Roswell section on my skin. It was okay with endocrinologist, but she was very late calling me for the appointment. I'm starting telemed diabetes classes.
Okay. The use of telemedicine will be influenced by the quality of the technology you have at home and the quality of the technology in general. We had just experienced ourselves something that happens. I moved my screen because I wanted to get my iPhone to show it to you. And for reasons that I'm not clear about, I went blank. Okay, so that happens. But you have been visiting your physician's office when a call came and the physician had to leave the room. So interruptions in the contact are not new. It's a type of interruption and how frustrated you may or may not be with it. For those in the audience who are at ease with current technology, and I'm assuming that this is not a representative sample because you are participating on a sort of a teleconference situation, you may be able to navigate that and do it successfully. The problem is those that do not have the technology or are not able to use it to its full extent. I think that that will continue to improve. And I'm amazed at what I can do today with the iPhone or with this iPad. I'm using the iPad to talk with you. I have a full computer behind me, but this is better because I'm facing the window and I get better light. So fine-tuning things. If you're going to show the physician a lesion you have in your arm and the light on that you are using is not very good, the physician is not going to see it very well. Sometimes it's better to take a picture and make it available. Somebody asked about telemedicine coverage for Medicare. I want to address that one. Well, let's start. This is time of change. The issue with that has to do with the fact that prior to the pandemic, Medicare did not cover telemedicine. Furthermore, very little of telemedicine was covered. Why? Because the insurance companies, and Medicare is a form of state-provided insurance, did not have a way of measuring how much what has been done and how much has been done. Well, it's interesting because nowadays, in certainly in New York City, I know that mental health, telemedicine, not only is covered, is encouraged. Why? Because it has dropped non-compliance dramatically. Now, for many of us, myself included, and you in the audience, Buffalo winter is coming. How many times have you had to cancel a visit because the conditions were not adequate to go? Well, now you can change it to a telemedicine kind. And what you need to prepare yourself is to have the equipment that you will need to do that. I'm going to make another prediction here, and I'm going out on a limb here. But the insurance companies are going to see the benefit of telemedicine and will facilitate that every patient has a blood pressure machine, an oximetry, a glucometer, and whatever else comes along that would allow the patient to plug in their device and get the readings directly from those machines. Anybody in the audience that has a recent vintage cell phone knows that right now you can know your heart rate. You can know how many steps you walk in a day. You can, if you have the proper connector, you will know your oximetry. So the technology is there and will get better. So the insurance companies will see the value. Why? Because a lot of the money insurance companies have to spend is for poor use of opportunities for improvement on people, for instance, that have hypertension and not seeing the doctor. Non-compliance is common in diseases like diabetes and hypertension, and the outcomes of those two diseases are based or adversely affected by the non-compliance of patients. So if you can increase compliance by having telemedicine, the insurance companies are going to pay attention. Why? Because the cost at the end of the care are tremendous. And if they can postpone the cost or eliminate them, is for their advantage. Next question, Katie.
Will telemedicine be done of out-of-area advisors?
I don't know. I suppose that just the same way, I'm not sure that I understand the question. When you mean by out of area, can you call the Cleveland Clinic and get advice? I don't know. It may well be a similar process or situation to that happens now without telemedicine, when your care suggests that perhaps going to the Cleveland Clinic for a heart transplant or a kidney transplant may be a better idea. It is incumbent to the insurance company, Medicare also, to say, yeah, we will allow that or not. A lot depends on what they have in their own plan to cover what you perceive your needs to be. So I hope that answers your question. Next one, Katie.
Do you think it is easier for a patient to be honest with a doctor face-to-face or over the internet?
I don't see the difference. I think that face-to-face, look, I'm face-to-face right now with Katie. I don't see the rest of you, but I think it's a technology issue and we could substitute that. The whole thing has to do with communication skills. And everybody's, the physician and the patient's ability to properly negotiate the interface of communication. Let's go back to the question of asking how is it okay to ask the physician his age? Well, a lot depends on your body language. And I am now paying attention to my body language. What am I doing? My arms are crossed in front of my chest and I'm leaning forward because I'm looking at my own image and I want to make sure that I have my face right there in the middle. I could talk like this too. I could sit back and relax. And so body language is important. And then the use of open-ended questions is important. And also when you have a strong feeling about something, begin your sentence by saying I, meaning yourself. And the sentence, let's say, let me play the patient trying to ask the doctor for his age. Doctor, I have reached an age where I feel necessary to make sure that the doctor that I choose will survive me. So I'm compelled to ask you this question. How old are you? I think that's a perfectly solid, valid explanation. So check your communication skills. If you are shy, you may have a difficult time in either situation. But that's part of the equation. I hope I answer that at least partially.
I think so. We have a couple people that are just saying they love the convenience of the telemedicine appointments, hope to use them in the future. One person has mobility issues, so that's so valuable for them. I have a person who made a comment, which I'm assuming is to the being honest face-to-face or over the internet. This person said probably over the internet because you're safe at home.
Yeah, true.
The next person in response to that, I think as well, is I can write in detail via text, think my condition out, whether it is in person, I freeze up. My doctor is female and I am male.
Okay, let me tell you tell you a technique that I have used and I welcome my patients to use decades ago. For the longest time, I'm being a physician and understanding that my doctor, when I was in the patient's role, that my doctor had time limits like I had. I would write down my complaint and I would write it in a format that I anticipated would be useful to the doctor. These are my symptoms. This is what I have experienced. This is what I have done about it. What do you think? And I will walk in the doctor's office and I will hand off to the doctor my complaint. My biggest disappointment doing that happened not long ago when I went to see an orthopedist because my right hip was hurting. And I did what I had done forever. I wrote down my symptoms and I wrote down my findings on my own, examining myself. Don't you know that day the orthopedist had a fellow working, meaning he was not done with training in orthopedist. So I go to the office. My wife comes along with me. My wife is a physician herself. So I hand off the note to this physician fellow. He put it away. He never read it. He started with his own history taking. You know what? At that very time, I crossed him off. Okay? I think that is, and when the patient will bring a note to me, I will make it a point to make the note a part of the chart because that becomes a document, and to make sure that the interview or the interaction was not finished until I have addressed every single one of the complaints in the little letter. Okay? So I think that that's writing down what you want to say is most important, and telemedicine should not eliminate it, because a good telemedicine system would allow you to either before the meeting or during the meeting put the text that you have written into the interaction. Katie, go ahead.
This is a comment to that. My doctors know me. I always come with written questions and I think they welcome it. And then I have a yes, agree.
Any other questions?
There's one other that's not related to what we're talking about right now. I'm happy to ask it, or we can wait till the end.
No, go ahead.
Oh, well, actually, this one just came in. How does MD training address the need for bedside manner?
Okay. Well, I tell you what. Well, I gave you the business about communications, and that is I'm faculty with UB, and what I am now what I'm involved with is the ethics course, and but in the ethics course I manage to almost every occasion I have to introduce the art of communication and to deal with the parts that I mentioned in speaking with you. What do we communicate with body language? The importance of eye contact, the way questions are asked. One of the most difficult things for medical students to learn is questions that relate to sexuality, mortality, and seriousness of illness. So, you heard Katie introduce me as working in the immunodeficiency clinic at ECMC at the beginning of the 2000s. The immunodeficiency clinic was a euphemism. That was the AIDS clinic. As a physician, during the 80s and 90s, I had to learn to be at ease asking patients questions about their sexuality. I had not been trained. Medical school did not teach me that. At the same time, I had to learn to ask questions about their patients' views about their own mortality. What, with advanced directives? Imagine the law at some point around 1990, not the law, but the insurance companies. I remember this clearly. It happened with healthcare plan, which is the predecessor of today's Univera. They made it a requirement that for a chart to be complete, there ought to be a notation about the physician having asked the patient about advanced directives. And that applied to everybody. And my initial reaction was, you mean to tell me that I'm going to ask a 17-year-old person whether they have made decisions about what they wanted to do if they became ill and they were not able to talk to the doctor? Yes, they said. And at that time, there were a couple of critical cases. There was this young woman who was, I forgot her name, that was in a vegetative coma for a long time. And I realized that it was true. So I had to train myself into being able to ask the questions about mortality and being at ease, because I could not be tense myself if I'm going to ask questions. The patient will read my being tense, and just to train myself. So back to the original questions, are students being trained? I think they're training themselves at the bedside. I am not, and I may be absolutely wrong on this. I am not, but I'm not aware of their having attended courses where bedside manners are taught. Now, you also heard Katie introducing my work at the Office of Professional Medical Conduct. That's the New York State Department of Health branch where the 800 number you call to complain about your physician is located. So at some point in my career, in my late career, I became the physician that no physician wanted to see because it had to do with complaints about you. So it's a common problem. I'm sorry to know that. I'm sorry to hear that. But we are not all at our best all the time with all patients. Next one, Katie.
Okay. This is a little different. There are half a dozen COVID flare-up spots in New York State. All but one are downstate, largely located in Orthodox Jewish enclaves where large weddings or large funerals were organized. Western New York is the other location. What's going on in Western New York?
According to the newspaper today, they don't know. They just don't know why we are peaking. I think that they will find out. Just from my observations walking around, I think that people are not as compulsive about following the necessary things. Wear a mask when in public, keep your distance, wash your hands. I think we drop our guard. And look, I've been locked in, I guess, since the end of February. When we went to New York City in April, it was no freedom at that point. We just traveled, got there, masks on, and it continues. And this wears on you. So I suspect that when we know everything that there is to know about COVID, we are going to be able to retrospectively explain why those things that you are referring to, or the questioner asked. Let me put out a comment on the Orthodox community in, I think it's Brooklyn. That is basically the same Orthodox community that decided to go against the measles vaccine. I don't have an argument for their argument. The only argument I have is one that they may or may not accept. And that applies not just to that community, it applies to everybody who denies or resists the idea of vaccination or following public health rules. So if I put my mask on, and this is going to be a make-believe mask, if I am talking to you like this, I'm giving the message that I hope you hear, muffled as it is, through the paper. But I'm also giving the message that I follow the rules, number one. Number two, that I am not just protecting myself, I'm protecting you. So, when I suppose back to being contemporary to each other, we grew up at the time when many of us, I certainly remember the polio scare. I have friends that acquired polio. My best friend, my roommate in medical school, had survived polio and had a skinny right leg as a result of it. At that point, in Argentina, polio immunization was compulsory. Now, there is a country in the world where, in Afghanistan, the Taliban is opposed to polio vaccination. Why? Who knows? I don't know. Obviously, the government there lacks the power to just make it compulsory. In the United States, freedom in all levels allows human groups to just decline vaccination, and some could become militant about it. So I don't have a solution for it other than education and continue education. I am hopeful that a COVID vaccine will be available. I don't know when. I don't think it's going to be any sooner than the spring. And I am hopeful that people will understand that it's important to get vaccinated. If I, Lito Gutierrez, hear that a vaccine is available, and the CDC and the Public Health Service says, yeah, this is a good vaccine, take it, I am going to be there first. In fact, let me tell you further. I am in line to get my vaccine from my primary care physician at the senior flu vaccine level on October 23rd or 24th. So I'm already lined up for that. I believe that vaccines work. I have seen cases of diphtheria. I've seen cases of rabies. I have seen cases of cholera. So, folks, vaccines, public health does work. And so enough of that. Next.
Well, this is a comment, Dr. Gutierrez, you're wonderful, so kind and accomplished. Thank you so much for your time. How can we seek out your MD services presently?
I no longer carry a registration. I gave that up because it's too costly, and I don't practice medicine anymore. I found out how to do things, and I don't need to practice anymore. So, no, the only thing I do that is medically related is a public health counsel. So that's it. I can tell you that I follow my own advice. My primary care physician belongs to a large medical group that has an excellent cadre of nurse practitioners and PAs, and I use telemedicine.
Thank you. That person said LOL. I think this is back into response about the bedside manner. This person says they take medical humanities, learn by example.
Yes, and in fact, when I have my chance to talk with medical students about it, I recommend that they go to old literature, particularly the writers of William Osler, who was, I mean, the internist par excellence, a Canadian who ended up teaching in the United States and John Hopkins, and then ended up in Great Britain, and it's superb. He wrote a book which, if you're interested in that kind of reading, is called Equanimitas, a fabulous book describing his philosophy of practice. There is a collection of short stories, vignettes, that is available through the American College of Physicians, but you can get it through Amazon also. It's a series. It's 4 books on being a doctor. Michael Lacombe began this. Every single vignette is impactful. Many have brought tears to my eyes, and it's worthwhile reading. I have not. I make a confession. I never recommended these to a non-physician readership, but if you are inclined and you have time, On Being a Doctor, Michael Lacombe. Lacombe is a French, L-A, capital C-O-M-B-E.
Thank you. So those are the only questions and comments I'm seeing right now. We have a couple more minutes, so I'll give a couple seconds if anyone has any last-minute thoughts or comments. Otherwise, Lito, thank you so much for your time this morning, for sharing your expertise with us.
Okay.
It's always a pleasure working with you. Yeah. All right. So just a couple more seconds here. Otherwise, I think we can end. Oh, I'm seeing thank you, insightful, wow, learned a lot. So,
okay.
All right.
Thank you. Thank you very much. Have a good day.
Right.
Goodbye,
you
everybody.
Too. Bye, Lito. I'll talk with you later.